Welcome to this video series on arrhythmias in the emergency department. Using a case-based approach, we will explore 6 worked ED cases across the tachyarrhythmia and bradyarrhythmia spectrum, focusing on reasoning frameworks, key decision points, and the common pitfalls that challenge many trainees. Our learning objectives are fourfold: applying a structured framework, recognizing instability early, naming high-stakes traps, and reasoning through contested areas where clinical guidelines may diverge. Consider these objectives a roadmap for the session. Every arrhythmia in the emergency department can be managed using these 4 sequential questions. First, is the patient stable? Second, is the QRS narrow or wide? Third, is the rhythm regular or irregular? And finally, what is the underlying mechanism? This matrix organizes tachyarrhythmias by QRS width and regularity. Categorizing a rhythm into one of these 4 quadrants is a powerful tool to narrow your differential diagnosis within seconds, preventing the common error of premature pattern matching. Recognizing instability is critical. Signs include severe hypotension, altered mental status, or ongoing ischemic chest pain. If present, prioritize immediate synchronized cardioversion over pharmacological trials. Remember to rearm the sync mode after every shock. In our first case, a 27-year-old presents with sudden onset palpitations. Her ECG shows a regular narrow complex tachycardia at 182 beats per minute. She is hemodynamically stable. Let's evaluate this presentation. Our differential for a regular narrow complex tachycardia includes AVNRT, orthodromic AVRT, atrial flutter, atrial tachycardia, and sinus tachycardia. Differentiating these is key to selecting the correct management strategy. For stable supraventricular tachycardia, consider the modified Valsalva maneuver using the revert protocol. This involves a postural change that enhances vagal tone, significantly increasing the success rate compared to the standard technique. If vagal maneuvers fail, adenosine is often used. It works by causing transient AV nodal block. Always check your local protocol for dosing, and remember to inform the patient about the expected, albeit uncomfortable, sensations of flushing and chest tightness. The response to adenosine is itself diagnostic. Abrupt termination confirms an AV node-dependent circuit. If the rhythm remains but reveals flutter waves, the node was a bystander. If there is no change, reconsider ventricular tachycardia. In case 2, a 74-year-old presents with sepsis and atrial fibrillation with rapid ventricular response. It is essential to determine if the arrhythmia is the primary driver of instability or merely a passenger to the underlying sepsis. If the AF is a passenger to severe sepsis, aggressive rate control might actually worsen the patient's hemodynamics. Prioritize treating the driver, such as managing infection and fluid status, before focusing on the heart rate. When you decide to treat, choose between rate control and rhythm control. Rate control is often the default for stable ED presentations, whereas rhythm control is reserved for specific cases where instability or significant symptoms are present. Use the CHA2DS2 VASC score to frame the long-term anticoagulation conversation, but remember, it does not dictate your immediate management decisions in the emergency department, where stabilizing the patient's acute physiology is the priority. To conclude this case, always prioritize source control for sepsis and reassess the rhythm afterward. Document your reasoning clearly, specifically whether you treated the arrhythmia as a driver or a passenger, to assist future care teams. Case 3 involves a 22-year-old with pre-excited atrial fibrillation. This is a life-threatening rhythm. The key features are an irregularly irregular rhythm, a very fast and variable rate, and wide, bizarre QRS complexes that change morphology with every beat. Recognizing this rhythm is critical. Remember the tetrad: an irregular rhythm, wide complexes, extreme rates, and shifting morphology. These features differentiate it from monomorphic ventricular tachycardia, which is typically regular. The most dangerous mistake here is administering nodal blocking agents like adenosine, beta blockers, calcium channel blockers, or digoxin. These drugs block the AV node, leaving the accessory pathway as the sole, unhindered route for conduction, which can trigger ventricular fibrillation. Speed is the treatment. If this rhythm is identified, you must act immediately to avoid fatal outcomes. If you suspect pre-excited AF, treat it as such. A cardiology consult is far safer than incorrectly administering a nodal blocking agent. Moving to case 4, a regular wide complex tachycardia. A 61-year-old patient with a prior myocardial infarction presents with palpitations. A common trap is to assume supraventricular tachycardia with aberrancy when you should be assuming ventricular tachycardia first. In any patient with known structural heart disease, A wide complex tachycardia must be managed as ventricular tachycardia until proven otherwise. This assumption is a vital safety heuristic that prevents the use of harmful medications. Look for AV dissociation, capture beats, or fusion beats to support a diagnosis of VT. While algorithms exist to aid in rhythm identification, they should never be used to override a high clinical suspicion of VT based on the patient's history. Management is guided by hemodynamic stability. If the patient is unstable, proceed directly to synchronized cardioversion. If they are stable, antiarrhythmic therapy is indicated, though agents like verapamil must be avoided, as they can cause cardiovascular collapse. Case 5 focuses on torsades de pointe. This 68-year-old patient, currently on a new QT prolonging medication, suffered a syncopal episode. The rhythm shows polymorphic VT with a twisting axis and a prolonged baseline QT interval. It is essential to distinguish between long QT torsades and normal QT polymorphic VT. The baseline QT interval is the key. Torsades is often pause-dependent, while polymorphic VT with a normal QT may point toward ischemia or other underlying syndromes. For torsades, treatment involves addressing the precipitant, replacing electrolytes like magnesium and potassium, and using overdrive pacing or isoproterenol to suppress pauses. Avoid any further QT prolonging agents in these patients. Finally, Case 6, complete heart block. A 79-year-old patient presents with syncope and a heart rate of 34. The ECG shows complete dissociation between P waves and QRS complexes, which is diagnostic of high-grade block. While atropine is a first-line consideration for bradycardia, its success is limited in infranodal blocks. Prepare for transcutaneous pacing immediately. Always confirm mechanical capture by feeling for a pulse that correlates with the paced rhythm. Do not focus only on pacing. Look for reversible causes. In this case, the patient's existing medication list, which includes beta blockers and calcium channel blockers, may be a significant factor. Treat these reversible elements in parallel. In this final summary, remember that special populations, such as pregnant patients, athletes, or those with existing devices, require individualized assessment. Never rush to add medication without first considering the underlying physiology and potential for reversible causes. We have reached our segment on contested areas. These are not settled facts, but places where expert guidance and clinical practice often diverge. We will cover topics like amiodarone safety and pre-excited AF, the 48-hour rule for cardioversion, and variable protocols for atropine dosing and rate control targets. Here are 10 key take-home points from our session. Prioritize stability, use synchronized cardioversion for instability, master the modified Valsalva, interpret adenosine responses carefully, and always look for the driver in AF. Remember that wide complex tachycardia is VT until proven otherwise. This video synthesizes evidence from major textbooks and guidelines, including AHA, ESC, and key trials like REVERT and PROCAMIO. Please use these as primary resources. They are essential reading for any clinician managing cardiac arrhythmias in the emergency department. Thank you for joining this series. I hope these frameworks help you navigate complex rhythm management with more confidence. If you have any edge cases or strips that defied the rules, I welcome your questions and discussion.